Hi, I'm Jennifer Matelski, a current dentistry and oral surgery resident at the University of Minnesota, and I'm here to talk about the recent research that I've been working on called the effect of alternative palatal root access technique on fracture resistance of root canal treated maxillary fourth premolar teeth in dogs. Circled on the top is the maxillary fourth premolar tooth in a dog. It's a large functional chewing tooth, which means it is also a frequently fractured tooth, and a tooth that we want to try to save whenever possible. After a complicated crown fracture, the only way to save this tooth is with root canal therapy. The first step of a root canal is accessing the inside of the tooth. This is usually done using a high-speed burr to drill a hole into the crown of the tooth and gain access to the root canal. Once we've accessed the root canal, we can now perform instrumentation, which means cleaning out the root canal with a series of special files and making sure everything's disinfected. After that, we fill the root canal, called obturation, with an inert material, and then finally seal it off so no bacteria can get in and cause further infection. Generally, access for root canal therapy of the maxillary fourth premolar tooth can be achieved using two access points on the cheek side of the tooth and allow instrumentation for all three roots of this tooth. However, occasionally, the palatal root, or root nearest the inside of the mouth, can be difficult to access through this method alone, and we have to employ alternative methods. Some of these methods include making one of our cheek side accesses bigger, making a new third access directly over that palatal root, or removing the palatal root. In humans, there are many biomechanical studies relating to access size and the long-term strength of the tooth after root canal therapy. Currently in dogs, we do not have any similar biomechanical studies, and we don't know whether our access methods affect the strength of the tooth long-term. Thus, our goals for this study were to determine if there were changes in fracture resistance for these access methods, and also to compare fracture resistance of untreated maxillary fourth premolar teeth with our root canal treated maxillary fourth premolar teeth. This would allow us to give owners proper expectations and to make proper clinical decisions based on the long-term function and goals for that tooth. In order to do this, we obtained 40 maxillary fourth premolar teeth, all from dogs of the same breed and similar age. All of the teeth were then divided into 4 groups of 10, one group with our standard access method, one group with an enlarged access on the mesial root, one group with a third access over the palatal root, and one group where we extracted the palatal root. After that, we performed standard root canal therapy on all of the teeth. After root canal therapy, we performed biomechanical testing of all of the teeth treated and recorded the maximum force sustained prior to fracture to determine the ultimate fracture strength and evaluate whether there were any changes between our treatment groups. Ultimately, the mean maximum force sustained prior to fracture for all of the teeth was 831 newtons. This is compared to a mean maximum force prior to fracture of 1,281 newtons of previously loaded structurally intact teeth. In our study, there was no significant difference in the mean force to fracture between the control group or any of our treatment groups. As we did not find any significant difference in fracture resistance between the standard access method or alternative access methods, the findings of this study suggest that the treatment option chosen when faced with a difficult-to-instrument palatal root can continue to be based on clinician preference and experience. However, given the significant difference in fracture resistance between the teeth in our study and previously tested intact maxillary fourth premolar teeth, this finding does suggest that, as is true in humans, root canal-treated teeth in dogs may be significantly weaker and more prone to fracture than structurally intact teeth. Additional studies are needed to confirm this finding and help determine how often additional methods to protect root canal-treated maxillary fourth premolar teeth, such as crown placement, are indicated. This manuscript is currently pending review and will hopefully be published sometime this winter. I'd like to take a moment to thank my mentor, Dr. Goldschmidt, as well as the University of Minnesota Dental Research Center for Biomaterials and Biomechanics, and the U of M CVM resident and graduate students research grant for making this possible.